Good afternoon, everybody. Am I audible? Am I am I visible?
Yes, ma'am. Both.
Thank you. Thank you so much. So it's a real pleasure to be here this afternoon, and I know it's a great conference that's been happening. I've been getting in and out of the conference, and the speakers have been great. So a very good afternoon to all the listeners, the viewers. And do I just start off, or is there anything else? Anything else that we need to do right now?
No, ma'am. Over to you.
Over to me. Thank you. Thank you so
Yes.
much. Thank you.
Yeah.
Okay, so I'll start sharing my screen. Is that okay for you?
Yes, ma'am. Please share. Share the
Sure.
screen.
Yeah, external.
Right. Is the screen visible?
Yes, ma'am.
Okay,
It's
cool.
visible. Thank you.
Right. So this is one of my patent topics on sarcopenia and the older adult, because it's a lot of research that's going on right now. We're doing it in Eastern India. So I'm from West Bengal, as you can see. This is from Kolkata. And we have our physiotherapy colleagues in Bangladesh as well, who are doing avid research on sarcopenia. In fact, I have two of my master's students who are just about completed their, finished their dissertations. So uh, the fact remains that sarcopenia as a disease is not very well researched upon, especially in India. It's not very, there are no guidelines for it. And all the more reason we physiotherapists need to work on this, because this is going to be our domain. There's no other professional who can work on sarcopenia as we can. And we should and step in and form guidelines, give guidelines, and do our research in order that in future, when government agencies wake up to the fact the sarcopenia as a disease needs to be looked after, then we are the presenting professionals for it, and it doesn't go on to orthopedics or rheumatologists or some other professionals. Yes, it's a group activity, it's teamwork, no doubt, but again, it's going to be us who are going to be dealing with sarcopenia. So exactly, I'll just share what I'm going to talk about today. So the first thing is, I've said about sarcopenic older adults, and we need to define who are our older adults. And then in India, how many do we have? Do we really need to be concerned? Because everyone says India is a young country. Then we, I mean, you must have understood by now that sarcopenia is a disease of the elderly. So that's what we are looking at. We also need to understand how active are these older people, the elderly, and what are their levels of physical activity, what is their fitness level, and what is their functional capacity. Because if we start prescribing them exercises, we need to learn this first or know this first. And I'm sure that most of us, sitting here, do know, but it's a good idea sometimes to just take a quick rain check on things and see exactly what it's about. Then then how active should they be? I mean, are we going to ask them to run marathons, or are we going to ask them to suddenly become active? So what would we actually recommend for them? And then we have a very simple exercise prescription. And when I go through the exercise prescription, you'll probably think, oh well, this is what I do know. But then when you're dealing with the older people, you do need to be extremely careful about, do I need to prescribe this, and should I not prescribe that? Because you surely don't want your older person to turn around and say, I did your exercises, I actually have more pain, and so I don't think I want to exercise anymore. And then there's going to be a barrier in their thinking. They'll probably never exercise again. So first of all, what do we mean by older people? So one particular definition is, old is when you're napping and everyone is actually worried that you're dead. It sounds a bit gory, doesn't it? But then that is it. And a lot of times when older people nap, people actually wonder whether they're actually asleep or they're dead. So sounds mean though. And again, when we really have to look at older people, do we really have to understand that, oh, because they're above 60 or because they're above 70, are they old? No. Age, the chronological age is definitely not an accurate predictor of what you are. It's basically your lifestyle, your the amount of exercise you do, what nutrition you have, what how do you manage stress, the genetics. People in the mountains are much better than people in the plains. People in the rural areas, the ones who do physical work, are better than the ones in the urban areas. So your environment, everything seems to have a contribution towards this, and that is what we really need to understand, that how much of it is really contributing to what we have, what we are right now, and what we will become when we are older. So we all age, but we all age differently. That, in a nutshell, that's what's true. And that's why it becomes difficult to do research on older people, because it's not a homogeneous group. A person of 60, maybe one person of 60 may be, groaning and moaning with pain all the time. Another person of 60 may be out clubbing and playing tennis or squash. And so it's not a homogeneous group. And traditionally, when we say someone's an older adult, they are those people above the age of 50. And 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 now you can understand, from 50 onwards, up over and above 50, there are going to be significant variations in health and functional capacity. Most importantly, it's good when the older person actually identifies themselves. I have this problem, and and I this could be the reason. If this happens, then the battle is half won. Now, in India, like, it is all okay to talk about the world, but in India, the scenario is different. We used to have a lot of older people, who used to have social security vis-a-vis their families, whereas now we are all going towards a nuclear families, and so a lot of older people have economic issues or health issues because of that. Now, we also need to understand how many older people are we looking at. And so when we look at this entire census thing, we are just going to be looking at this number. As of now, we are 143 millions, or I mean, there are so many older people in the year 2021, 143 million. Now, this as a percentage of our population is not much. It's probably 10% of our population. So that's not really much. But when it turns down in numbers, it's a huge number, and that's a huge patient population that we are looking at. And as physios, this patient population should be of interest to us, because these are the people we are going to help and treat. So the other issue about lifestyle today is that physical activity is disappearing from everyday life. Why? Because the transport pattern has changed. Who goes in a cycle? Can you imagine a 60 plus person going on a cycle to his office? No, no, no. There's no issue. There's no way that the person is going to do that. Or also, you are scared of letting a very older person, go in a public place, because the roads are congested, the footpaths are congested. The footpaths in Kolkata definitely are broken up. I mean, quite a few places. You don't even want your parent to walk on those footpaths. God knows where they're going to trip, where they're going to fall. And sport has not become a activity anymore. It's more of an entertainment. I'm sure all the guys here in the audience, and as well as some of the girls, I mean, are going to be crazy over the cricket that's happening in Ahmedabad right now. And also the impact of information technology. I have more older people coming across with their upper back pain and neck pain, because they're consistently looking at the telephone, because for entertainment, and the telephone or the tab has become their new friend. Also because they are lonely, this does ease off their loneliness. So this entire thing about increase in sedentary lifestyles and physically less demanding lifestyles is what is also causing a lot of issues. So this sarcopenia is an inactivity related disease, where we do understand that even if we as healthy individuals are put on 1 week of bed rest, our strength reduces by 20%, and there is a significant impact on the bone mineral content by 1%. Now, think about the older person. An older person spends around, people above the age of 70 spends a huge percentage of their time just lying down or sitting. Let's say not lying down, but at least sitting. So how much of their strength are they going to retain, and how much of their strength are they going to keep, or lose? So this is where we need to look in. And so sarcopenia has, there's an international classification of disease, and sarcopenia has been given ICD number 10 CM because it's an age which is a disease which is associated with decline in muscle mass. Sarco actually means flesh, and penia, as we all know from osteopenia, means deficiency. So sarcopenia means deficiency in muscles, and it was initially described by Rosenberg in 1989, and it's not so old, and that's why most of us will understand osteoporosis or osteopenia, but how many of us will actually look at sarcopenia? And so it is defined as, association with loss of skeletal mass, function with advancing age. So age is definitely in proportion to the amount of muscle mass that we lose. But along the moment we lose muscle mass, what happens? What happens is there's a functional decline. People function less than what they should. There comes increased episodes of diseases. There is hospitalization. There are increased incidences of fall, and then we do know it's a vicious circle, because a fall means reduced function, reduced mobility, and increased mortality. So this is what a sarcopenic muscle looks like. This is a normal muscle, and this is what a muscle looks, after sarcopenia has occurred. So when we look at the MRI pictures of the same, then this is what a sarcopenic muscle looks like. Look at the amount it has shrunk, once a person has sarcopenia. So it's a vicious cycle. When sarcopenia occurs, mind you, it starts with advancing age, and it can occur from as young or as old as greater than 30 years of age. It is proportion to age, disuse, reduced activity, and it is associated with reduced mobility, frailty, which is another aspect, osteoporosis, and a risk of falls. It affects all muscles, even the respiratory muscles, and therefore we have more respiratory tract infections in older people. It also affects the GI tract, and so older people have more GI tract disorders, constipation, and other issues with the GI tract. It can also cause diabetes and middle age in people who are very obese. And in totality, there's loss of physical function, and there's loss of independence. As of now, most of us are independent. We don't understand what it is to be dependent for your basic lifestyle or for your basic existence. It's not a happy existence. In India, what we have is that these are a bit of research that I can share with you. Now, this was basically a huge study which was published in 2016, and it had people above the age of 65. They found that the prevalence was 17.5%, whereas another one which was done in Chennai, you had people who there was a prevalence of 15.8%. Now, there has been a study in Odisha in a tertiary care center, and there has been a prevalence of, let's say, if we average between male and female, is going to be around 17%. Now, we've done a lot of research in India and Eastern India and Bangladesh, and we find that when we're looking at pre-sarcopenia, now there is a system of classifying sarcopenia. So when we look at pre-sarcopenia, we have as many as 61% males and 78% females who qualify to be pre-sarcopenic. Now, this is what I want to lay stress on. If we identify them as pre-sarcopenic, and if we can work on them, they don't move on to become sarcopenics or severely sarcopenics. But if we don't do that, then again, if we as physios do not have a role in preventive medicine, if we just have a role in curative or rehabilitative medicine, we're not really going to go much ahead. So our role needs to shift, and we need to identify people older than 50. Are they pre-sarcopenic? And then work on them besides the other problem that they've come to you with. And you will find that as a physician, as a physician physiotherapist, your practice, your entire outlook towards patient changes, and the patient also definitely gets much more from you than just a cure for a neck pain or a low back pain or a leg pain or a knee pain. So there are many measuring instruments, and when I bring down the list of measuring instruments, which is a scale that one can use, especially the PGs can use that. All these are various scales and questionnaires that they become. SPPB is basically a physical function test, which tests your balance, gait speed, and the amount of time you take from the chair rise. Skeletal mass index is obviously, as we all know, appendicular muscle mass by height square, and the BMD, whole body DEXA, the grip strength. Now, these are all measuring instruments, and each one of them is employed at various stages to describe a population as pre-sarcopenic, sarcopenic, and severely sarcopenic. I'm not getting into that because that would possibly take up all my time. But these are the test tools that you can utilize to kind of grade a patient as pre-sarcopenic, sarcopenic, and severely sarcopenic. Why do we need to act? I mean, what is the big thing? You might turn around and say, I mean, I don't even deal with sarcopenia, and why do I need to really know about it? Is, as I said, if we don't work, someone else is going to come along and take this entire population out of our domain, and we will then be saying, oh, well, why did we not work on this? Because this is definitely what we need to be doing. Now, what happens is that if we as a profession can work on sarcopenia, and even if there's a 10% reduction in the sarcopenic population, there's going to be a huge amount of saving of money. And although, because sarcopenia contributes to many other health problems. So as osteoporosis, as diabetes, as cardiovascular diseases, as respiratory tract diseases, as has an impact on your kidney function. So everything would be interrelated. If you can work on sarcopenia, you're actually making the population healthy. And so what happens is that when an individual is healthy, the family is better off. When a family is better off, the society, and then the country. And I think that that definitely needs to be a done thing to make older people not okay, or not get rid of their pain, or not help them once they have had a fracture. You want to preserve their independence and physical function and the quality of life, so that they don't end up getting a fracture, or they don't end up in a hospital bed with other comorbidities. So the best evidence for sarcopenia is basically your exercises, which is aerobics and resistance training, which is where we come in, and the other bit is their nutrition. And a lot of older people tend to eat less, they tend to not have the right kind of food, so that is extremely important. But what actually concerns us there is of definitely their exercise levels and their what they should be doing. So how active should older people be? What are the current recommendations? It's basically 30 minutes of moderate physical activity on 5 occasions in a week, which adds up to basically 150 minutes of exercises, which is, in a week. Now, that could be just walking, or just moderate physical exercise, or strength exercises that you and I can prescribe for the older adult. Now, those who cannot achieve the recommended 30 minutes can work towards their target 10 minutes in the morning, 10 minutes in the afternoon, 10 minutes in the evening. But you must stress upon your older adult person that this is what they could be doing to achieve that independence, to achieve a disease-free life. So the other aspect that you can actually work on is basically encourage them to get into group activities. You know how people go to parks in the morning and have a laughing club, or have a social club. Older people do that. So they should be encouraged to do that. They should be encouraged. Grandchildren are the greatest scope for older people to work with. Once there are little children in the house, older people will push themselves out of the chair or bed and work with the grandchild. So some household chores, some going to the vegetable market, getting vegetables for the house, and all this, some small activities that older people should be encouraged to do so that they remain active. What is the problem with our culture? the moment an older person starts working, we say, no, 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 you sit, you relax, we are there to work for you. And that's a part of the Indian culture, because we feel that that is looking after them, that is, giving them respect. But that boomerangs, because the moment they stop doing activities, they would tend to have other comorbidities, and then eventually will come a time when they cannot do much at all. So can we help to change matters? Can we, given put in some effort? We as physiotherapists, can we make them change? Can we prescribe them something? So yes, we can. And so it is recommended that an older person, to prevent sarcopenia, should be involved in strengthening exercises, flexibility exercises, and balance exercises. This is a must and it's recommended. Now, in our center, we tend to use a lot of Thera-Band. So I'm going to take you through a whole lot of exercises which includes Thera-Bands. I have the evidence for that, and this is the evidence. If anyone's interested, especially the PG students, in case you want to do research on sarcopenia, I'd be happy to share all the evidence that I have. Now, this is simple exercise. Let's say we are looking at strength training, and you might turn around and say, big deal. I mean, I'm going to ask my older adult to just do strength training for the elbow flexors. But let me tell you that it's the elbow flexors which we use maximum. When we pick up a book, when we pick up a cup of tea, or when we pick up a glass of water, when we put that spoon of food in our mouth, it's the elbow flexors working. And also when we pick up something bigger from the floor, maybe a shopping bag, or some vessel or something like that. So bilateral elbow flexion is because when we do bilateral activities, then a lot of our core stabilization is required, and uh, a lot of our core stabilization is required, and we would have to balance, and also a lot of more neuro facilitation occurs when we do Thera-Band exercises. So this is one of our older people who is like actually doing a seated row in sitting, and we emphasize on that because here she's working on her posterior muscles. And here again, remember, when we have to reach out for anything in front and bring it back to our side, we need these muscles. The other reason why we need these muscles is because older people tend to become kyphotic, and so when we work on the upper back muscles, we are actually reversing the process of kyphosis and working on that. And so that's that. Now, next is we have what is called the shoulder bench press in standing. So here we are looking at a bench press again for muscles where you can push. So let's say an older adult who's working at home needs to be pushing a door open. So many of them actually turn around and say, I can't seem to push, I can't seem to do any activity, which involves me to use a little bit of strength in our arm muscles. So again, look at it, it's bilateral activity where they're not only using their shoulder muscles, but they're also using their triceps. And this triceps is used even when they do a sit to stand, or when they have to balance themselves in sitting. Then again, we have something like an upright row in standing, where we have a very simple activity. You are going to be looking at a Thera-Band exercise where you do an upright row. Now, what is so significant about an upright row? This is what stabilizes the rotator cuff muscles. And when we work on the rotator cuff muscles, what we are looking at is an older adult who will be able to do their functional activities without injuring the shoulder. I do not know about you, but I get a significant number of older people with a shoulder problem, a tendonitis or a capsulitis. Why? Because they had just reached out for an overhead baggage cap in an aircraft, or they had reached out to pull up their luggage from the conveyor belt, or they had picked up maybe a lady had picked up a pressure cooker at home, or a briefcase or something. The moment they did that, they felt a small tinge in their shoulder and they ended up injuring their shoulder. So basic exercises with the Thera-Band, we need to be careful as well, because there should be no initial tension in the band. The initial tension in the band should be minimal, and then as we pull up the band, the tension builds up. The bands, as you all know, are color coded. So we use a tan color band, which is a light cream band, or a yellow color band initially to train our older patients, and then we can progress to a red or a green or a blue. So a chair squat is a good one, where a little bit of band under the feet gives you a bit of stability challenge. And we have kind of worked on it in a different way, where we actually make them do a chair squat where a sit to stand. So after we train them for a chair squat, we actually ask them to do a sit to stand. So this is a basic functional activity. Most of your patients in this age group will say, when we sit on low height surfaces or getting up from the car seat, or doing a sit to stand from the bed level is very painful, or we find it very difficult. Now these are activities with the band that you are able to do and train them with. Simple stuff, as you can see. So these are diagonal movements, and these are all functional activities. When we have to reach out overhead, bring down objects from a shelf on top, or put back things on an overhead shelf. Then you would reach out. We've got it in both directions. This is from top to bottom, and then there are, when you can anchor it from the bottom to top. So these would be your very simple activities that you would be training the older adult with, because these are Thera-Bands. Thera-Bands give you resistance, and you can actually dosage your older adult with that. You would go for a hamstring strengthening, where this would benefit the knee, and you would also go in for a quadriceps strengthening. So where they would actually work on these band exercises. Again, the reason why they would work on the band is neuromuscular facilitation. They can use weight cuffs as well, but the band has greater benefits. And so here there's a leg press. It is working on your hip muscles, your quadriceps, as well as giving you a close kinetic chain exercise for the lower limb. So as you can make out, there is nothing significant or very great about. In fact, the exercises are extremely simple. But do you need to complicate the exercises? Definitely not. You need to keep the exercises simple so that your older adult can do them. They do not have increased pain post exercise, and they can actually enjoy the exercise session, which most of our older people do. The other part of training, once you've done with strengthening, is flexibility training. And here in flexibility training, you are looking at increasing the range of motion. You are also targeting the reduction of pain and soreness that may have occurred when you were doing the strengthening exercise. And when you make a person flexible, you actually improve their posture, and you also reduce their muscle tension. So all this happens with flexibility training. Now, so remember, at the end of the day, whatever you give your patient, if it does not help them in their life, they are not going to practice it. So you have to keep a target, and the target actually is looking at this. See, if the person says, I have a functional limitation of getting dressed, then you're looking at upper and lower body flexibility. If the person says that, when I park the car, I find it difficult to look behind, then you're looking at neck and trunk flexibility, and so on and so forth. Like for when I can't bend down to pick up objects from the floor, you're looking at trunk and lower body flexibility. If they cannot reach out and place objects overhead, you're looking at upper body flexibility. So this is what you want to make your patient fill up. You want to make your patient tell you what activities they are having problems with, and then you can work on the flexibility of that part of the body. When you do that, then what happens is the person says, yeah, today I could actually reach up to that level of the shelf, or today when I bent down once, I could pick up an object. And that is your cue that your flexibility is working. But can flexibility work on its own? It would need strengthening, right? So you would have to strengthen that muscle part so that they do not get injured when they stoop down to pick up an object from the floor. But to be able to stoop down, you also need to give them flexibility. And that is why A lot of times we do not have individual research on flexibility. Most of the research combines strength, flexibility, and cardiovascular exercises so that they can do a complete program and they dose the patient accordingly. Now, what would be the dose for a flexibility program? You would do an initial warm up. You would just do 3 to 5 stretches of the upper body, lower body, and trunk, depending upon what functional limitation the patient has. You would hold it for 10 to 15 seconds or 5 breaths of normal breathing, not quick breathing. And target the muscles prone to tightness. Again, if there's a specific functional target, do that patient will want it. We don't need to do flexibility more than 2 days per week. Strength training can be done at least 3 days a week for the older person, but flexibility training is 2 days per week. And these are the kind of flexibility exercises that you require. You need to stretch the upper cervical flexors. You need to kind of stretch out the pectorals. So this would be the pectoral stretch. They're sitting on a chair. They could just sit on a stool and work on this. Then besides that, we had a physician who came to us, and we were working on his pectoral stretch. He just was so much happy because he said that my entire posture and my flexibility of my body is so much better when I came onto this program. He was just 61. A hamstring and a calf stretch, you can, when we do the hamstring stretch like this, if we actually dorsiflex the ankle, a calf stretch will happen simultaneously. But of course, we can do a calf stretch in standing. This would improve their gait and their stair climbing. Mid-back stretch would help them to reach out things from the center table and also to stoop down and lift up things. An overhead stretch would help them to reach or lift objects overhead. A side bend is just for general flexibility. And this is important. A lot of people are still driving, and in today's world, when they find it very difficult to turn around, or when someone calls them, and so instead of just turning their head and their upper back, they actually turn around their entire body, which is not desirable because then they may lose balance. So this trunk rotation is a good idea to be doing. Whereas very simple and very easy to do. Now, what kind of a stretch would you advise? Would you advise assisted stretch or an active stretch? Ideally, an active stretch. You don't want to assist them. You want to do an active stretch, which would build. It kind of helps in flexibility. It improves balance also, and then most important, it prevents injury. A lot of times you get patients who say that they've been overstretched by their physios. So you don't want to belong to that category. How much ever they can stretch, let it go slow. It doesn't matter if it goes slow, but they need to stretch themselves. The last component for the sarcopenic older adult is balance training. And we do know that 1 in 4 persons over the age of 65 will fall in their home. And after that, the story doesn't sound good, because then they end up with a fracture in their hand or their hip. Because of this, their mobility reduces. Because of that, comorbidities increase. So reduced balance is actually cause more falls, and older adults, especially if they've got weak muscles and because they are not flexible, are definitely more at risk. And so along with that, the other factors that contribute to reduce balance is medication or dizziness, and certain environmental factors, like everyone's got tiles in their homes nowadays, then they've got small carpets. And so older adults, if they don't have strength or if they don't have flexibility, they're not going to have lots of balance, so they would tend to fall on these obstacles more than you and I. So this is how balance training can be performed. There's a complete protocol here where you can actually do the balance training here. in our center, when we do a balance training, we do it again twice a week. The evidence says that a person who wants to undergo balance training and to see improvements in balance training must do it for at least 9 weeks. And you need to challenge all the systems like visual, vestibular, somatosensory. So you would kind of go about having them closing their eyes and putting them on a soft surface, and then after you've done all that, you would do a balance training, then you would do a walking, then again you would do balance training, and then again you would do a little bit of a different balance training, and then a cool down. So it's quite an intense session of 60 minutes, which you would do maybe with music or without music as your center has facilities, but it's a worthwhile session to do. And there's research which said that when they did this balance training, there was a significant improvement in the training group as compared to the control group. Now this lady had come to us, and she, look at her gait, she was walking on a broad base, and you can make out that there is no arm swing, and the trunk is tilting from side to side as she walks. She had had a couple of falls, and the family was a bit concerned, so they brought her to us. So we went through balance training where we actually trained her on the treadmill as well, and her gait was slow, understandable. She is an older person, and she walked slowly. You can make out a physio behind her for safety. We also made her do tandem balance training, with obstacles, where she went in and out of these obstacles and learned her way, zigzag walking and all that. The physio is getting trained as well. So uh, then there is tandem walking, where again physios behind her, and we've just utilized the line between two large tiles of granite, and or rather slabs of granite, and she's doing a tandem walking. So, again, it's not that everyone can do this. It has to be based on individual requirement. You must do a warm up because it's important, and there are protocols, but modify the protocol as per your patient population, and also as per their requirement. If your patient requires to go out and walk in public places, then train them accordingly. If your population is, or your patient requires to do just short levels of activity, train them accordingly. And so, because when it is customized, patients feel more looked after. They feel that yes, my problem got sorted, and that problem is not a universal problem, it's an individual problem that you need to understand. Also, in older people, remember, they would be having plenty of comorbidities, so you would look at the underlying pathology and address that as well. So, warm up exercise can be anything, just walking or cycling or treadmill. We tend to use the cycling because it's very easy. Or you can, of course, do the typical warm up that we do in the gym, do the various body motions. So, now look at the result of this. This is her same video that I used initially when she was training. Okay, so that time she was walking slow. We understood that. But here, look at her after the training that we did of obstacles and tandem walking. Look at her speed, look at the confidence, look at how she's walking on the treadmill. She's a short lady, and so she's got these short steps and she's walking fairly briskly. But this is so rewarding when you can actually have an older person walk well, walk with confidence, and know that they are not going to fall again. So at the end of the day, it's outcome that matters. When you're training a person with balance, you need to guard the patient, like you saw that the physios were doing, and you need to avoid fatigue. A lot of times older people are very nice and they say, no, 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 I'm not tired, I'm okay. You do as much as you want to do, but you need to understand that they do get fatigued, and then they start compensating with other muscle groups. Look out for those warning signs and ensure that they do not compensate. Use as much support, like let's say this older adult has got a chair by the side, just in case he needs support, give it. You don't have, you're not going to make them circus, they're not going to be trapeze walking or something. You're just looking at someone having a better balance, and so this is how it would help them. Then our own yoga is there. They can do yoga asanas. Extremely important to do yoga asanas. And the same yoga asanas are performed by a younger individual, which could be more challenging in terms of the amount of effort that is put in. But for the older person, the yoga asana should be modified, that comorbidity should be considered, and then the yoga should be accordingly prescribed to them. It should not be a generic yoga session for all. um, However, how much ever we understand this, older people don't. They have their own belief patterns, they have their own attitudes, and they are not motivated, definitely. So sometimes they say, nahi nahi, kuch nahi hoga, I don't want to do it, nothing will happen to me. Sometimes they've had a previous bad experience, so then they don't want to do it. And uh, also, the doctor is not prescribed it, so why should I do it? And I mean, I'm not going to come to your center every day, so I can't come twice a week. How am I going to come? Who's going to bring me? So I can't do it. The parks are not good, they're uneven, there are a lot of children in the park, I feel scared. Or the streets are not well lit. So these are the kind of things that influence them, and they feel, no, no, I can't get out. And now the biggest barrier is COVID, where a lot of older people have not got out because of COVID. Now, so we need a different spin on fitness. We as I said, instead of giving them a lift, just say climb up one story. If you are living on the seventh floor, say just climb up one story and then take the lift. Or like sit on the floor and do the puja, or sit on the floor and let's eat one meal sitting on the floor for flexibility. Balance and agility again to climb stairs. Open a door with a key. Don't step ahead and say, no, no, let me open it for you. Let them open, let them be independent. Don't do things for them thinking that this is the way to show love and affection. They need to be independent, and that's the way to go about it. Then be with them when they're crossing the street, but don't hold their hand, just be with them. So see how quickly they cross the street on their own. And take them out shopping, take them out on holidays, let them go, so that they learn to walk during holidays. Everything can't be in a car or on transport. It should mean a lot of walking. The moment we stop walking, the day we stop walking, that's where we invite all the troubles in the universe. So I'm just summarizing it. Physical activity can contribute significantly towards successful aging and prevention of sarcopenia. And although everyone knows that physical activity can confer a wide range of benefits, the majority of older people just remain inactive. They just don't move. So even small amount of activities can be beneficial. So encourage that. Even when a older person has come for any other problem, ask them to walk, ask them to be active. And there are many opportunities. Most people say, "Acha, baad mein karenge," but that baad mein never comes. So you need to encourage them, and the mindset of the older person has to change. You have to bring in that change for the older person, so that has to change. At last and not but the least, all I can say is that um, it's like a very popular Sanskrit saying that man eva manushyanam karanam bandha mokshaya, which means that uh, it's a mind over the body. If the man hi manav ke bandhan और मोक्ष का कारण बन सकता है. So if the mind is not convinced, the body will not move. So it's the mind which has to tell the body to move. Otherwise, the person stays in that bandhan, and they do not get the freedom to be independent. And that's all that I have to say. I would really welcome a few questions in case you have any of them. I'll stop sharing.
Yes, ma'am.
Anybody?
Anybody? Any questions? So far, we have not received any in the chat box. But ma'am, it was a very interesting and very elaborate session on role of exercise in sarcopenia. Ma'am, I'm Dr. Piyusha. I've enrolled for
Hi, Dr.
physiotherapy. I'm an associate professor here in this college.
Right.
And I felt instantly connected when they told me that your session is there on exercise prescription in sarcopenia, because my PhD topic is on sarcopenia.
Oh, wonderful.
Yeah.
Oh, wonderful. This is great.
So I said, no, I want to be a moderator for this session because I will be very much interested to learn more about it. And
I'm so glad. I mean, we're doing so much research in Eastern India. We would love to share and collaborate with you.
Exactly, ma'am. That is what came to my mind when I heard that you are doing research with your PGs. I thought we can collaborate on it further, because as I saw in the literature, of course, very less is done in India on sarcopenia, basically. So definitely there is a lot of scope to go ahead with this idea. And my topic.
We have translated the Sarkol to Bangla as well, to Bengali. So it's one of the very elaborate questionnaires. Of course, since you're doing your PhD, you must have gone through the Sarkol. So we've translated that. We've done that in Bangladesh. So we've translated that into Bengali because we have the same language between Bangladesh and West Bengal. So we've done that, and we've also we've carried out prevalence studies in Bangladesh as well as in Kolkata. So if we could carry out a similar study in Maharashtra, then definitely that would be wonderful.
Yes,
what is your topic on? What exactly are you looking at?
Exactly. I am looking forward to compare yoga, hatha yoga, and high intensity interval training in postmenopausal women population.
Okay.
Like after 46. I have just taken women because they will tend to put on weight after postmenopause, especially in the central obesity increases. So my target is basically the central obesity. I actually thought of going ahead for sarcopenic obesity topic, but then I learned that the prevalence is quite less as compared to only sarcopenia.
Right.
The combination of sarcopenia and obesity,
it
is difficult. So then I went ahead with the sarcopenia plus postmenopausal central obesity in women.
It's an excellent topic. I mean, an excellent topic. I would be so interested in reading your outcomes and your results. Anytime if you want to discuss, I would be happy to talk about it.
I will be in continuous touch with you, ma'am, because I will need a lot of support and a lot of guidance from you.
Wonderful.
So very happy to get connected with you, ma'am.
Thank you so much. Thank you.
Yes, ma'am.
Thanks.
Ma'am, one question we have received.
Okay.
I work in an elderly care inpatient ward currently, and sarcopenia is quite common. Given that my patient is 80 to 90% functional with only generalized weakness, are there any particular types of exercises you would prescribe? You would actually know when we spoke about strength, flexibility, and balance. We don't expect. I mean, most of the times all three exist, but at times we find that it's only strength which they lack, or they just lack functional independence, and the strength and flexibility are quite okay. So somewhere you need to move back and analyze exactly what the cause is. So if they have lack of strength, then why is that so? Is it because they don't exercise at all, or is it their lifestyle which is such, or is it because they've been admitted in your ward for a long time and therefore they're just generally deconditioned? And based on that, strength training, I think, is what most physios do very well. And we would start with low number of repetitions. We would dosage it with the Boggs scale and see that although I have shown Thera-Bands here, and we do use Thera-Bands, we would use the tan color Thera-Band, or maybe initially no Thera-Band, depending upon the patient's presenting strength, and make them go through all the major muscles, including the muscles which are generally involved in older people, and including the muscles which are commonly used for function, like the quadriceps or the hip extensors or the triceps, and definitely target them and work on their strength training, keeping the Vogue scale of rate of perceived exertion as the dosimetry for the number of repetitions that you would be doing for the patient.
Thank you, ma'am. And if we were to do a group session of patients with similar functional capabilities, is that a possibility to conduct?
Yes. We've done that.
Yeah.
Sorry. Continue. That's a beautiful
and the person has written she is based in UK currently.
Right. Of course. I mean, like in UK, I remember even long back, group sessions were very popular. Even for the knee or for the hip, I remember we used to get in people who would be just the knee patients or just the hip patients and make them go through a series of exercises. So for sarcopenia, if you get a homogeneous group and you've like realized that they are nearly the same level, then they would actually enjoy that. And also they would meet each other. It's so lonely out there. A lot of them are they're just living alone. So if they have more people with similar issues and they can come to the hospital, have a group session with you, nothing like it. And then of course you would keep in touch over the phone or whatever method they choose to communicate, because sometimes they do get demotivated. So you would do that. But excellent thought. Yes, of course, group therapy is a great idea.
Ma'am, few have congratulated you and a lot of appreciation that extent motivating session.
Oh, thank you so much.
And interesting presentation.
Thank you.
For elderly.
Thank you so much.
Thank you so much. Indeed, it was a great presentation. I will definitely drop in a mail to you, ma'am.
Please do that. Let's collaborate. I'd be really interested in that because we've been looking for collaborators.
Yes, ma'am. Definitely. Thank you so much, ma'am. Thank you. Good day.
Thank you.